Okay, well, Bill, again, thank you so much for pulling not just one, but two quite spectacular sessions together. Everybody is just raving about the first session, and I know this next one is going to get a little bit more into the weeds about what we can do. And
Right.
so it's particularly fitting that you've sequenced it this way. But again, we just are amazed by what you have done in putting this together and how you stay up on all the science that's relevant. I daily learn from you and your various communications.
Part of it is because, a good part of it is because of what we're going to be talking about is the way science has been transformed. So I think we're going live. So
we are live, and it's over to you.
All right. Well, it's a great pleasure to begin this panel that follows a discussion of COVID seen from really the international and very national level of politics. And at the very end of it, we were talking about what are the bright spots. And my final comment was there are two bright spots. First of all, people that we're talking to, people like you, who devote your lives to doing your best to helping others, whether it's from the political level, like Helen Clark, whether it's from the government service level, like Peggy Hamburg, whether it's like Jeffrey Lehman or Sandra Galea, who are in education, whether it's somebody like George Daley, who is running one of the more interesting medical enterprises in the world today, or my friend Clay Marsh, who I see now online, who is dealing with the West Virginians on this issue on a daily basis, both from a point of view of health and policy. From Lael, who is in there in the trenches, working on pediatric COVID and making amazing contributions. I mean, her productivity is unbelievable. If you track her productivity, all of a sudden COVID comes along and it's about 10 times what it was before. And it's a whole infrastructure that makes that possible. And Roberto Patarco, who has got enormous experience in a wide range of issues, who's joining us today. But let me just give a more formal introduction to the panelists. George Daley is the first speaker. He's Dean of Harvard Medical School. And he has a very distinguished research career as well. He has his MD from Harvard, and he was a postdoc in the same lab I was, but some years later with David Baltimore, one of the truly monumental figures and mentors that we both shared. And he came along a little later, but and has really made major advances in cancer, leading to the discovery of Gleevec, which is a very successful, one of the most successful cancer drugs of all time, and then leading stem cell research, a wonderful field that's just expanding in all sorts of directions. And we'll talk a little bit about that. So that's George. Roberto Patarco has also an amazing PhD, MD background. Dana-Farber, we connected. He was in my laboratory for a while. And we actually had the pleasure of seeing the sequences of HIV for the very first time. And I have to say, seeing that sequence and what you could do with the sequence is the first time you had the sequence of the virus before you had the whole virus. You didn't know what the proteins were. All of a sudden, it was like a roadmap. And it was that moment of clarity when Roberto and I put the sequence with the protected proteins around our whole conference room that led me to create Human Genome Sciences, to realize that genomics could open up the progress for science in a most amazing way. It wouldn't give you the drug, but it would give you where to look. It short-circuited the time from phenomenon to drug target by about 20 to 30 years. That's what genomics has done, because you can now say, this is a target, this is a gene we have to go after. And it used to take you forever to go from disease to tissue, or to organ, to tissue, to cell, to protein, to gene. You can do that instantly. And that changed the way science is done. And Roberto was a key part of that. He's gone on to have a very distinguished medical career. And it will join us, especially relevant to his background in chronic fatigue syndrome relevant to long COVID. He's written many books, including a definitive text on what it is and how you treat it. So it's a really important contribution, and people are looking to that kind of work to understand really what's happening next, the pandemic after the pandemic, that I'm beginning to call long COVID. Lael has done remarkable work in pediatric pulmonologist, sort of the right person at the right time. She's a very active collaborator in the program we're going to discuss at the outset, which is mass CPR, very, very active. Just 2 weeks, 3 weeks ago, she led the whole discussion. But she's here to tell us about how cooperation has really informed her work and allowed her to do what we do. And of course, Clay Marsh has got a very important role. He's the COVID czar of West Virginia. He's been very close to the governor. He and I have had deep discussions on all levels, including Zen philosophy and his approach to COVID and other issues. But he's right there in the trenches, dealing with some of the more complex disease and social problems and political issues. He's fortunate to have a governor who wants to do the right things. But how can you do the right things when the people don't want you to do the right things? And are you really doing the right things for them if they don't want it done for them? So those are questions we could get into. But I think before we really do that, I'd like to say, for me, one of the signal changes that has happened through COVID, and one of the really bright spots, is global cooperation. That from the very beginning, although there's a lot of noise about what happened early in China, the moment they found the virus and got the sequence of the virus, it was worldwide. It went all over the world and allowed people instantly to begin to do vaccine work. Within literally less than a month of that sequence being published, there were vaccine candidates. That is like unheard of. And it was the Chinese that did it. They did that. They let the information out. And since that time, there's been a level of scientific cooperation and communication, I think, unprecedented in world history. The only thing I can kind of think about is what goes on within the country during a war, where all decisions are coordinated and everybody's working together in the same team. Think of the Manhattan Project. But the Manhattan Project certainly wasn't shared with the rest of the world. That was, although we did, well, it might have been, we did intend it to be. They were very good spies. Some of these 12 Soviet spies in Los Alamos, but this is deliberate cooperation. And to lead off that discussion, I'd like to have George take us through your thinking of putting together mass CPR, how it works, why it works, and then more importantly, perhaps how we can extend this. When I looked at the president's program on HIV/AIDS, which is an amazing program, we've saved tens of, really millions and millions of lives in Africa. It's been very hard to extend it past HIV/AIDS. Is it possible that we're going to extend mass CPR past COVID? I hope so, and I hope you'll address that. First, describing what mass CPR is, how it works, and your hopes for broader engagement on a variety of issues, especially issues like mental health, which I know you and I have discussed. So George, off to you.
Yeah, Bill, thank you for that introduction and the opportunity to talk about this, because I think we're all struggling to take the lessons from the pandemic and imagine how we could be more effective in other areas of, as you mentioned, chronic diseases, mental health, and beyond. So let me just talk a little bit about this Massachusetts Consortium on Pathogen Readiness, which is a mouthful, but we've shortened it to mass CPR. Harvard Medical School is the anchor, and we are an unusual community in that the medical school proper doesn't really control the affiliated hospitals, and we're really a hub of this huge ecosystem, almost 12,000 faculty, 15 affiliates. But what we do at the medical school is act as a convener of trans-institutional endeavors. And those are some of the lessons that we're learning from. So mass CPR is really a prime example of that. And our hope is that it will certainly be something that we can extend into other areas. So Mass CPR is a multi-institutional collaboration. It's anchored at Harvard Medical School, but it involves all the 4 medical schools in Massachusetts. So we've got UMass and BU and Tufts as well, all the teaching hospitals and affiliated institutions like MIT. And then there's a number of biotech companies. And I would argue it is a really formidable brigade of scientists, physicians, clinicians, public health professionals. And it was formed in early 2020. Let's we can trace it to a historic meeting on March 2nd, which was the first day that we reported community spread in the Massachusetts area. Fortunately, the congregation of about 80 scientists did not turn into a super spreader event, but in fact, it acted as a nidus for organizing the community. We are going to be celebrating our 3rd anniversary next March. And in those 3 years, we've engaged more than 800 collaborators over those 17 institutions. And just to talk about some of the productivity, the 70 investigators who were directly funded by Mass CPR have published now more than 500 highly impactful research articles on SARS-CoV-2 biology, on disease. You know, obviously there's a lot of very fundamental insights about the behavior of the virus, the nature of the host pathogen interaction, and the like. But there have also been a number of really, really important public health impacts, especially in the development of 2 of the major vaccines. I'll talk just a little bit about that. So, you know, when you're bringing together a community to encourage collaboration, you've really got to work on the incentives. And there was no doubt that the urgency of the pandemic created a strong incentive. And you know, some of the ways that we realized we had to work together to confront the pandemic had to do with being able to just collect a huge array of biospecimens. And the fact is that when we brought together biospecimens from all of our founding hospitals, we could then very rapidly assemble tens of thousands of biospecimens. And we had to leverage containment facilities that no single institution had. So we went to the Reagan Institute and we went to BU's National Emerging Infectious Disease Laboratory. And those initial strategies, bringing together collaboration, bringing together biospecimens, have already been challenged. So I think we've already learned some lessons. So think about the collaborative model around monkeypox. Nesli Bazgaz, an HMS faculty member based at the Mass General, was the person who identified the first case of monkeypox in the US. And then very quickly, she turned to a variety of colleagues that were engaged in Mass CPR to start characterizing the host response, the virology of human monkeypox, and to, again, start collecting and leveraging samples. Another area that maybe Lael will speak about is the building of patient cohorts and the forming of teams of investigators to study the aspects that only these patient cohorts can reveal. So my hope is, you know, this consortium that was started because of the urgency of the pandemic is really a new model of collaborative science. I think we've all learned that we can get along. Cooperation bests competition in every case. And we're really hopeful that this Mass CPR model can be applied to other persistent health problems. And as you mentioned, mental health and beyond. So I look forward to discussing more of that in response to questions.
Well, I've got a whole lot of questions and fleshing out some of the details. But I would say one thing I've enjoyed is Mass CPR reaching beyond national borders, both to other first national borders, but also involving workers in Chengdu, workers in Shenzhen, workers in scientists in South Africa. I know they've had an important part of that. What was when you were setting up Mass CPR as a Massachusetts entity, How did it come to be open to the world?
Yeah, well, one of the great opportunities presented by the pandemic was that we all had to be shut in, and yet we had this remarkable community resource called Zoom. And we were very much in the early part of the pandemic partners with the Chinese scientists led by Zhang Nanshan at the Guangzhou Institute for Respiratory Health. We held in early February Zoom conferences where we exchanged information. I mean, it was truly extraordinary to be witness to the first pathology coming out of the patients in Wuhan and the enormous impact that had on our community. We were given advance warning of the tsunami that was going to hit us, and that helped us to respond. But as you said, we were able to convene on various Zoom calls, as you know, several hundred investigators at a time. And Bill, I so appreciate your engagement because you were a thought leader on so many of those discussions that ranged from the pathogenesis of the virus to the activity of the vaccines and the like. And again, over time, we have reached out. I believe we've engaged something like 80 different countries. You mentioned South Africa. We're very close in touch with the folks in Northern Italy when the pandemic was hitting there. But investigators from University of Washington to the South. It's a really extraordinary opportunity for us to bring the world together. We are one very small planet, especially when you've got a very active virus.
Oh, thank you, George. We're going to go to Lael now. And Lael, you've been on the ground, one of the really active participants and beneficiaries of this research collaboration. And I'd like you to describe your experience and what differences it made to you as a researcher in this most important area of pediatric COVID.
Yeah, definitely. Thank you. So, you know, as you, Dr. Daley said, the tsunami was coming, and we knew it was mostly adults who were affected by COVID. We wanted to see, really what we wanted to learn was, can we learn anything from kids that might be helpful? And so that was our initial goal. And so when kids came into the hospital, we wanted to collect as many samples as we could. So, and we wanted to align with the existing adult biorepositories. So, you know, we joined these meetings and just sort of listened in and listened to where, you know, how things were organizing, and asked for copies of their protocols so we could do things in parallel to see, you know, make sure that we weren't just picking up on differences in how we collected things or how we processed. We wanted them to be identical. So we tried to align all of our efforts, and then we needed to get these samples. And so when kids were coming in, they were really coming in early because their parents were in the hospital and they had no place to live, and they were found to be positive. And so, you know, we collected those samples, but there weren't many. Most of the pediatric floors, in fact, were shut down and filled with adult patients. So we then, you know, we were just constantly thinking, where can we find these patients? Let's go to the screening clinics at Mass General. And that was a good sort of place to look. But then there were hotspots outside urban suburbs that we had to connect with. So we connected with the medical directors and the leaders to see what we could do. And I have to say that setting up the biorepository really was, it's challenging collecting samples in children. So we had to be very mindful of that. And it's you know, research is less integrated in the pediatric setting than is in adult settings in general. So we also had to be mindful of that, sort of be sensitive to providers and what we were asking for nurses to do and everything. So I think that the very first level of collaboration was really with the clinics, and not just the medical directors who could give us the, you know, thumbs up that we could collect these samples, but it was also the nurses. We wanted to make sure that we had their buy-in, and that we weren't asking, we made life as easy as possible for them. But we also tried to talk to them, and we would give, you know, group sort of overviews of what we were doing and why it was important. And I think that that was actually very important to get everybody's buy-in at all levels.
Who would you say your major collaborations are to make the new breakthroughs you've made in understanding pediatric COVID?
So there's the clinical side is one aspect, but then the research side is a separate aspect. And so also these similar meetings and that were being established would listen to people. But again, with pediatrics, you have to be very careful with your samples because you can't get tons of tubes of blood. You might have like 1 ml of blood that you can use, and you have one shot. And so you have to really be mindful of who you collaborate with. So going to the meetings and listening to people talk, and we wanted to find
So it helped you be selective of who to work with.
you had to be selective.
Making a judgment, is this somebody doing what I want?
So there were, we wanted to make sure that what we were getting would have a lot of information. So we didn't want to ask too focused of a question, but we wanted to align.
Can you give us a specific example?
So I would say a really great example and a really great collaborator has been Galit Alter, who does really extensive, deep profiling of antibody responses. Tons of people were doing antibody responses, but she really got, multiple levels. And that's really not only, those have been really productive collaborations, not only in defining what kids look like with COVID and how they respond, but also with this multi-system inflammatory syndrome in children, which is the sort of, post-COVID severe illness that kids get. And also vaccine responses. And so we've been, and not just in kids, but in babies who are born to moms who were vaccinated. So we've gotten all of this really in-depth information and what's effective, what's not effective. And so that's been
you to have that call. Is there something that was special about mass CPR that allowed you to work with Galit?
Yeah. Absolutely. Those are often the meetings. I'd hear some data presented and I'd send a little chat, have you thought about what this might look like in kids? And we'd set up a phone call afterwards, and then we'd go through some data. So definitely, we looked at viral swabs with John Lee, who is leading the adult biorepository, and he's presented a lot at Mass CPR. He's, one of the main people in looking at the viral response, and that was actually really informative early on. People thought kids were spared, but in fact, we found that they're infected and carry high infectious load, but they don't get as sick. So that's important from a public health sort of perspective.
In fact, the kids have a lot of virus, but they don't get so sick, but they can certainly give it to somebody else.
Exactly. They can bring it home. They can, and now,
I had my grandchildren go to what I call COVID camp. Soccer camp, and they came back and they infected the whole family. So
I know it
that was what soccer camp did this summer with the second round of infections.
They do that coming back from childcare with lots of other viruses.
So absolutely they do. But was there any special protocol that allowed you to send your samples without extra red tape? Did the Mass CPR?
Being part of the Harvard, being Mass General Brigham Harvard, it was easier. Definitely easier.
Because the Broad isn't where you work. You don't work where.
I'm at Mass General. Yeah.
And Galit isn't at Mass General. She's somewhere someplace else.
Right. But sort of within that community, very easy for transferring samples. And the whole process was very easy, even when we were, collaborating. I think there was just a priority at that time as well. So we were able to get samples transferred and shared pretty easily.
We'll get back to talking about pediatric COVID as an entity, but Roberto, I want to go to you now and talk about long COVID. In the last session, I described it as the pandemic after the pandemic. That if it's only 1 or 2% of people that have really serious symptoms that prevent them from working, that's a lot. That's estimated to be something like 10 to 15 million Americans. The Europeans are having even larger numbers. It's already hitting a job crisis. That's not even counting the human, that's just in the economy, but you're talking about the human impact of this. You've spent years working and thinking about chronic fatigue syndrome and what the issues are there. Maybe describe a little bit about what we know about long COVID what the collaborations you listen to on mass CPR is contributing to that, and how you can contribute your knowledge to dealing with this new and growing problem.
Thank you, Bill, and thank you for the invitation to join this distinguished panel. It's a big problem to get our hands around, and it's not the first time we're dealing with this. Unfortunately, we've proven as humans to be very inept to make things happen. And I think, and I'm very optimistic in the sense that we need to bring together three pillars. One is government, the other is industry, and the other I would lump academia, professional societies, and patient advocacy groups, for instance, to coalesce and cooperate and make the resources happen, because no pillar individually has the resources to make it all happen. And really not just at the discovery level or the diagnostic, but also bringing it to real world application and bringing it to all the communities that need it and the underserved communities, and then making this process global so that we also can make use of what I call natural experiments that are going on around the world because of the different genetics, the different social conditions, the different healthcare systems. And so there is a lot that we don't have to recreate. Even within the United States, if we go to our different systems and our different regions, and we take the Veterans Affairs Administration and we take the academic centers, and we have a lot to learn and to bring together. And I think mass CPR, and I've had the privilege to attend the meetings this last year, and they cover from pathogenesis to treatment to vaccines, and they, as Dean Daley mentioned, bring industry, and also people who are linked obviously with government at different levels, local, regional, and so forth. And the challenge is big, and this is where, if I may I'm allowed to do so, is go a little bit into the nitty-gritty fast on what the big challenge is with these diseases. Is these post-viral syndromes, and I wouldn't just say viral, it could be other microbes also. Whenever we face a battle with microbes, we could suffer organ damage, we can suffer immunity, because when our defenses are attacking the microbe, those defenses can end up attacking our cells. We can alter our immune system. We can reactivate viruses that live in us, like herpes viruses or endogenous retroviruses, and so many things. So there's bound to be a sequela, and the duration of that sequela can be very short, of days or weeks. It could be very long, all the way to a lifetime. And we've seen many examples with viruses where you have an exposure to Epstein-Barr virus, one of the herpes viruses, and you end up in a small subset of the population ends up getting multiple sclerosis. Or you're exposed to human T-cell leukemia virus, one virus we worked on with Bill, and develop leukemia lymphoma many decades later. So you may not be seeing the immediate consequences of the viral infection, but you have these acute and subacute and chronic and so forth, and things that manifest many years later. So at the end of the day, you know, when you have any patient coming in, whether it's chronic fatigue syndrome or long COVID, it still remains a diagnosis of exclusion. So you cannot assume, one, because the patient had COVID, that what they're suffering is long COVID. And many of us as physicians have sometimes made that mistake, and because of the bias. And we need to rule out many other things. And they come in with very nonspecific symptoms, headaches and shortness of breath and headache and brain fog, and et cetera, that are very vague and with a very long list, a very long differential of things that can cause it. So it's a big imposition on our system, and with all its limitations and the time and human and financial infrastructure and so forth. And the symptoms are not pathognomonic. It's not that if you say, oh, I see this, then it's this disease. And then when people try to create a definition, it suffers that it's not universally accepted. And sometimes you have to do clinical definitions or research definition. And some definitions, you may not even need a proof of COVID because that would discriminate against a whole bunch of people who don't have access to testing. And then the presentation is heterogeneous. It's not that everybody comes in with the same presentation. Some people it's very cardiovascular. It could be that they're suffering fainting spells, that they're dizzy, et cetera. Other people, it's more neurological with the brain fog and so forth, the attention problems and the fatigue. Other people, it's more immunological, and without immune diseases and other manifestations. And then when we try to study them, we tend to categorize them by these presentations into different groups. And that is an artificial, say, way of doing it, because in research, we have to work with as homogeneous a population as we can to be able to interpret the data. So that's why we start splitting people. And I'm going into all these details because there is frustration at the patient level, at the physician level, at every level.
Roberto has spent his lifetime looking at chronic fatigue, and every time we talk about it, there's so many issues, and I think these are issues that we have to bring up at Mass CPR too. We have to focus a little bit more than we've done because, we're going through the acute phase, and we're beginning to get a grip on what that is, what that isn't. But that isn't true with long COVID for kids, for adults, and it's another very peculiarity is that there's sort of a W-shaped curve for it. The youngest kids don't get it so much, but middle age, it's really a disease of the middle age, not of the old age. And that's really odd. I mean, there's a lot of really odd things about this, but I think the way we have to think about it is, the way you introduced it, Roberto, is that we've been hit. Probably, 80, 90% of kids have been infected. I think that's about the right number, right, Lael? If it's not 100%, it's like 80 or 90%. That's more than the rest of the population. Maybe, although they say a third of Americans have been infected, it's probably much more like 2/3 or more of the population has been infected. And if there's only 1 or 2% really serious lung consequences, that's a lot of people.
A lot of people.
And so we're going to have to deal with this as a medical issue. And it's not going to go away with the rest of COVID. We were dealing with the 1918 flu with Parkinson's disease in the 50s, 60s, and 70s. A long time we dealt with that. And some of these other long consequences. With polio, people have reactivation of paralytic symptoms when they're in their 60s or 70s or 80s. So once you're hit with such a massive infection of this virus, which I think the more I look at this virus, the more I understand how systemic it is. I mean, it's a really big hit to your system. It's not a little one. You're getting all sorts of inflammatory reactions. You're getting autoimmune reactions. You're getting lung, heart, kidney, almost every organ you can think of. Especially once you start affecting the vascular system, vascular endothelium. You're getting hits everywhere. And there are going to be long-term consequences. I think this is something Mass CPR can focus on. Bring the attention of people, psychiatrists. We need to bring psychiatrists into this more than we're bringing them, I think, into these discussions. People who are focused on wellness, I'm helping to edit a textbook on COVID. And one of the really positive discussions I've had was long COVID. People saying there are things we can do that aren't really serious medical treatments, but that we handle chronic fatigue syndrome through behavioral modification, through this, through that. There's a whole series of things we can do that are positive to help the patients. We have to sort of bring this kind of perspective into what we're doing. And we have, fortunately, some of the infrastructure in place. I want to get to some more questions about infrastructure in a minute. Before I do that, I see Clay shaking his head yes on some issues. I'd like you to describe, first of all, what it's like for you in your life in West Virginia, in being in your position with the population you have, which is at the very beginning, with the first one, you were the leaders for vaccine uptake, and then you weren't. And there's a whole series of issues like that you contended with, I have to say, with the best of humor. and some philosophy. But I'd like you to describe what it's like for somebody in your position to be immediately involved with COVID.
Thank you, Bill. And I also express great gratitude to the other panelists for the work they've done. And Bill, thank you for your ongoing help and support. Bill's one of my go-to guys, and I've had a lot of go-to questions. So just let me level set quickly. So I am a native of West Virginia, and my dad was the editor of the largest newspaper in the state. And internal to the newspaper was the motto, sustained outrage for social injustice. So that's the household I grew up in. And I had gone to medical school at West Virginia University and then gone to Ohio State University for 30 years. And I was called back by the president that was the president of the university when I was first in medical school, who had been the president of Ohio State twice. So the road back was interesting. When COVID hit, my role at that time, full-time, was to be the dean of the medical school at West Virginia University and to oversee all the health side of the university and to co-lead our health system, which is the largest health system in the state, WVU Medicine. And when the pandemic started, I had a conversation with our president and then with our governor, and our governor was very much on board with being very cautious about this, given that the problems that happened in Europe and then in New York City. And so we actually declared a state emergency for COVID in West Virginia before we had a single documented case. And as things went on, then we got one case, then two cases, then four. And as West Virginia has experienced throughout the pandemic, you know, we always have several weeks of lots of canaries and lots of mines that fall across bigger, more urban connected cities. And so we were, because we had been able to prepare, we were the first in the country to test all of our nursing home residents, and we created a task force. It sounds like the sort of the task force that you guys have created in Massachusetts, which sounds wonderful, but we really modeled it after Stan McChrystal's team of teams, and we called it the Joint Interagency Task Force. So that allowed us to have all the appropriate stakeholders around the table, including Long-Term Care Association, including state medical, hospital, manufacturers, FEMA, our Department of Health and Human Resources, et cetera. And we recognized immediately when the vaccines became available that the federal pharmacy program, which really would push all the vaccines to CVS and Walgreens, really wouldn't be as helpful for West Virginia, because in many of our rural communities, we did not have a presence of Walgreens or CVS. And we, with respect, talked to Operation Warp Speed and said that we think that there's a better option for us, which is to push our vaccines through our privately owned and family owned pharmacies that have pre-existing relationships with a lot of the long-term care facilities. And so we ended up being the first in the country to immunize all of our nursing home residents. And we recognized very early that this was a real problem of aged population, and we have the third oldest population in the country. So we also then made a decision strategically to really target all of our initial vaccines to people over 70 years old initially, and then we went to 65, and then we went to 50, because our data said that about 95% of our deaths from West Virginians over 50, and about 75% of our deaths from West Virginians over 75. And that worked really well. And as Bill said, we were doing well. We also leveraged the university, because early, like many other states, we started running into problems with personal protective equipment because supply chains in China and testing capabilities with swabs from Italy became in short supply. So we actually took out an importer's license in some of the Asian countries, and we got material. We used our toxicology inhalational research lab to test material and found that HEPA filters made really good masks. And then we found out that the governor of New York had bought 6 months of all of the HEPA material that were available in the United States. We went back to the drawing board, and we found that Gore-Tex was a good also substitute. So we made our own gowns, we made our own masks. And because the university is a land grant university of the state, Then we ended up designing the state's PCR capabilities, quantitative antibody capabilities, next-gen sequencing capabilities, along with our partnership with Marshall University, start a wastewater project to be able to observe and predict where we might have more problems, and then we brought next-gen sequencing to that. So we've continued to innovate and try to internalize our supply chains, because being a small state, we generally stood in the end of the line. And as we start to look at what's happened now with with the bivalent COVID vaccine, the research that we are really trying to do, and we're very much embracing this real world research concept, but is around implementation research. So we really want to understand how we take the stuff that we know works and then make it happen. And as we look in the country, for instance, the new bivalent vaccine that is, effective, at least in the models that have been tested, has only been uptaken by about 5% or so of the population at risk. And even our elders that are at high risk, the uptake's been really low. West Virginia is not great, but we're about 10% uptake in our over 65-year-old population and 16% overall from all of our eligible population. And when you start to compare countries like the US with countries like Japan, we see that your risk of dying of COVID-19 is about 10 times as high in the US as it is in Japan. And really, it's just because they were uptaking the vaccine at much more high levels, 95% across their entire population, and about half of their population still wears masks. So really simple, available sort of interventions, and also the recognition that in the US, more people under 45 got Paxlovid than people over 65, which is crazy because of the great benefit of Paxlovid. So we have the tools today to be able to really save almost everybody's life or prevent them from having the problem. And that's where this also interfaces so intimately with long COVID, which, as Roberto said, is a challenging disease because it has a myriad of presentations. And when you look at the studies with long COVID, there is a large background number of people that didn't have COVID that also have some of these symptoms that could be perceived as long COVID. So understanding how we are going to define the disease, understanding how we are going to start to categorize, as Bill said, there's many different underlying mechanisms that are thought to be responsible, different mechanisms in different people, including, disruption of critical pathways in the brain, reactivation to other viruses of the immune system, overactivation of the immune system, clotting mechanisms causing thrombi and vessels. So I think that we are, if you've seen the cartoon with the iceberg, we see just the tip. The rest of it underneath the water is pretty daunting. But I do believe that the collaboration, and I love what George said initially, my understanding is that all ecosystems in nature thrive only with collaboration, not with competition. So ultimately, I do think that we have created some very critical collaborations and have this incredible opportunity to try to refortify our health system and our response. And for us, part of the issue is there's no blueprint for COVID, and there's no blueprint for really correcting some of the health issues that we have. Certainly other countries have done things differently, but most of those countries are much smaller than we are. And so trying to come up with a more connected set of solutions around prevention, public health, starting to work on this implementation research. And from the conference, and I'll say one more thing and I'll stop, we also know from really great research from Blackburn and Appel at San Francisco, or Case and Deaton at Princeton, or the Kaiser Foundation with Adverse Childhood Experiences, that the way that you see your life, and do you see your life with hope or hopelessness? Do you see your life with scarcity and learned helplessness versus abundance and resilience, makes a huge difference on your biological age and makes a huge difference on your lifespan. So I think that there's many issues, including the real topic of this conference, which is how to target healthy longevity, because it's not your chronological age. It is your biological age that really counts. And I think that there's many things that we can do to try to improve the health and the biological age and resilience of our population. And some of those lessons I think will come to light from our response to COVID. Bill, back to you.
Clay, certainly not disappointed in your presentation. I'm delighted you could make it.
Thank you.
I think what you've done is take us from the laboratory and the hospital bedside to somebody who's really implementing these lessons in a very important way. And, you know, people like you are the heroes of this pandemic. You're really taking the best knowledge we have and trying to make a difference in a situation. It's wonderful to hear that there are people like you around this country doing the kind of work you're doing. And it makes all the work that the academics do all that more significant, because our job is to give you the tools to do what you need to do, right? And but let me go back to the.
Can I say one thing
Yeah.
real quick, Bill? Let me make sure though that I am really clear too. It's really the people like Lael that are the heroes of this. I mean, there's people that are working every day in anonymity who are doing the great work every day. And, you know, and I ask people, who was the last president of General Motors? And most people don't know. And then I ask people, who is Mother Teresa? And virtually everybody knows that. So I think that the servant's heart is really being seen by our healthcare workers. And I'm just so grateful to those folks. They're the heroes of this, not me.
Well, that's nice of you to say. Let's go back to the major topic. One of the things that I would say that's a hallmark of all these pandemics, I harken back to the early days of HIV/AIDS, when the gay community was excoriating every aspect of our society for neglecting this terrible disease that was devastating their communities. And, you know, there were times when I knew people were going to funerals twice a week. It was a terrible, terrible time. And they were right that most of society did not pay attention to them. However, they were wrong when it came to science. Science shone in that period. It was one, you know, I was part of it, but I was part of a community that took it deadly serious from the very beginning and worked amazingly fast. In those days, it wasn't in terms of 6 to 9 months, but it was a 2 or 3 years before we really understood what was going on, that the viruses were isolated. We got the first drugs. I mean, it was, for its time, it was amazing. And science really performed well. And we did it without the tools we have today. Today, we have these amazing tools. I'd say one of the basic tools that makes a difference is what scientific journals have done, which is allowed preprint publication. And George, you want to comment about that a little bit? You've been involved in looking at it, but the preprints, you now get data hot off the press. In mass EPRs, we get it preprint. It's better, but preprints are really important. I read these preprints every day, and you get to see the world emerging. So, George, what are your comments about that?
Yeah, well, I think that the pandemic presented an opportunity to legitimize these preprint approaches. There was a fair amount of debate in the scientific community as to whether or not putting unreviewed, basic drafts out into the sort of blogosphere would just overwhelm us with erroneous or faulty data. And the pandemic proved that that was not the case. In fact, the urgency required a much more expedited flow of information. And all of us would read those papers with great enthusiasm, but with the eye of a critical reviewer. And it's really, really important that the scientific community be able to use that filter and then be able to distill the massive amounts of information coming through to put it into action. I remember Lindsay Baden, who is the infectious disease editor of the New England Journal, saying that in the early days of the pandemic, he was getting something like 200 manuscripts a week. And I mean, just to be able to read 200 manuscripts, let alone get peer review and editorial input and then put them on publication, was a Herculean task. So I think we've learned a tremendous amount. I think the value of depositing data in the public domain is unchallenged now, and it contributed to the speed of progress. Speed of communication directly relates to the speed of innovation.
Let me just say that, I was deeply involved in the genomic revolution. And there, the rules were, if you were going to get government funding, you had to put your raw data, make it available immediately. I think that was the first real shock, that you basically had to take your machine feed and feed in the databases. And there were some mistakes. People contaminated the human database with bacterial sequences that took a long time to try to clean out. But on the whole, it was a huge success and continues to be a huge success. And we saw how important the genomic information was in getting rapid vaccine to be effectuated. But Lael, in your work, how much do you rely on what comes out in sort of the daily unpeer-reviewed literature?
Oh, definitely a lot. And you can sort of get a sense. I've started to learn which journals the preprints are going to based on their style. So no, it's everything's moving so fast and policies are being implemented so fast. And I've started to realize that doing research is a bit of advocacy. And so you need your research to be available to others to help move things forward quickly, but to keep up with the virus. So I think preprints have really played an important role. And so I definitely look to preprints to try to stay ahead and anticipate where, getting that final published journal is great. And actually, then, it's peer reviewed and is a great resource, but to stay ahead of things, I think they're really important.
Right, it's just an amazing transformation. Physics did this a long time ago. Physics sort of was the first to say, you write your equation down and put it, and then people will criticize. I want to make a comment to George about critical reading. I was educated in a lab of Jim Watson and Walter Gilbert, two very critical minds. And I learned that not only do you look at preprints with a careful eye, you look at everything that's been published. And so the way we were trained is they would take a paper and tear it apart, a published paper by a Nobel Prize winning scientist or some eminent person, and just completely shred it. And the lesson was the only thing you might be able to believe was the data. Okay, don't ever think that anybody's interpretation of data is correct. Okay, and even then, the data may be suspect because they may not have done all the controls they need to do. So we learned to read these papers. I think that's really important of education in general, is to learn how to be super critical. Don't take anything at face value. Understand that it's an observation. And when I look at the COVID literature, there's some papers that have 6 people and some papers that have 600,000 or 6 million people. And there's a difference in the conclusions you can reach from 6 million or 600,000 people from 6 people. And those are the kinds of things I think we have to be sensitive to. George, I want to go back to you and ask another question, which is, you talked about incentives. And I'd like to a little more, and that there were a number of people who had grants from Mass EPR. How does Mass EPR give grants? Where do you get the money? How important is that? Money's always important, I can tell you.
Yeah, well, I mean, other than the urgency of the pandemic, you also have to have the incentives of funding. Susan Hockfield, the former president of MIT, was fond of saying, our jobs as presidents or deans are herding cats, and it's very helpful to have a lot of catnip. And that's what we were able to raise in the early days of the pandemic. In the first instance, we were promised a very large amount of funding from the China Evergrande Group. It was fascinating. Harvard Medical School had an ongoing collaboration with the China Evergrande Group, who had supported a number of our institutes at Harvard in mathematics, in sustainability, and in immunology. And when the pandemic broke, you'll remember, our governments were not on the best of terms. There was a trade war underway, and there was a real concern that there wouldn't be the degree of scientific cooperation that was needed. And the China Evergrande Group came together, came forward and provided very generous funding to kickstart our collaboration with the Guangzhou Institute of Respiratory Health. And that rapidly—
George, I never knew. That's interesting. That's a very interesting observation.
Yes, yes.
And how much money was put up?
Well, so initially there was the promise of some 120 million US dollars that would be split between the US side, the Mass CPR Consortium, and the Guangzhou side. Ultimately, you may know that the China Evergrande Group ran into some challenges of over leverage, and they did ultimately, though, provide the Harvard side with about 14 million and the Chinese side with about the same. And that kickstarted us. We then were able to raise additional funding from folks like Mark and Lisa Schwartz, from the Bertarelli Family Foundation, from the Nancy Lurie Marks Foundation. And altogether—
These are all people who are deeply involved in the biomedical community. I think
Yes.
the Schwartzes are with Raygon.
Yes, exactly.
Then
The Schwartzes are
an
benefactors.
investor in Moderna.
Yes.
Yeah.
And Moderna, I'm probably not supposed to say this, but we've actually received funding into Mass CPR from, let's say, a prominent biotech company in our community.
Mhm.
And we have, we're very close to receiving another $12 million from two foundations, which are going to allow us to perpetuate the Mass CPR infrastructure.
That's fantastic. But this is COVID Mass CPR.
Well, it's Mass CPR, and I should also say the Centers for Disease Control recently provided a grant to the Massachusetts Department of Public Health that will include support for Mass CPR to run educational programs.
Is that the $25 million grant?
These Centers for Genomic Excellence.
This is a $25 million grant.
Yes.
That's a fantastic thing. So it looks like there's going to be some legs and some support for this. It'd be great to— now, next question, how is that administrated? How is that money given to people and to incentivize them? Yeah,
well, fortunately, we've had a very collaborative infrastructure. It's run out of the Dean for Research Operations at Harvard Medical School, David Golan, who's been extraordinary. But we have a steering committee of representatives from all 17 institutions. We have had a rigorous peer review process for deciding which projects are the most. I hope it's accelerated and quick. How quick is it? Well, I mean, when the first request for proposals went out in April of 2020, we received literally hundreds, and we were able to do peer review, rigorous peer review within a week. Again, in the urgency of the pandemic really put that front and center. We won't be quite as quick in the years to come, but we will continue to be rigorous. Right. That's terrific. So, Lael, how have you received funds from this, or have you?
I haven't directly, but I think it's made collaborators able to run the assays. So indirectly I have, because running experiments is quite expensive, especially some of the in-depth things that we're doing. And so it's that's been really beneficial in just being able to get the data, completed. Well, you'll have other opportunities, Lael. Come back.
That's
We haven't gone away yet.
Let's talk about how this model of throughout Massachusetts. Do you know of any other community in the country that has a similar organization? Clay or anybody else? You have knowledge of other cooperative groups of this nature and size?
I would just say, Bill, no, this is very, very impressive. And of course, because of the density of talent and the history, the de-risking of investing in the folks in the Massachusetts area. But I think it's really in many ways is connected to the country of Israel. And during the pandemic, to me, Israel was the go-to place to find real world data that was actually available for us to see. And remember, Bill, one of my calls was that we were thinking about trying to jump the White House and the FDA, or at least pressure them, because we wanted to boost, because we saw the benefit of boosting from Israel. And Israel, with their HMOs and Pfizer, had a research collaborative, and they were able to push out really, I thought, high quality data very rapidly, particularly around the vaccines and the utility of different ages and the impact of the vaccines.
They continue to do that.
I'm sorry?
They continue that to this day.
They do, but I think that's really the only other place that comes immediately to mind for me when you look at organization. And the UK also has a very strong organized research network, and they're able to report, but I think Israel, to me, has been the sort of—
Right, Israel was first, but I was—
Israel, certainly. There were, I think it's fair to say that most large academic medical centers convene some sort of collaborative strategy. The Bay Area in particular brought together a number of different institutions. And yet one of our advantages in Massachusetts is that we not only have a large number of outstanding leading institutions and medical schools, but we have this remarkable density. We're all within about a 5-mile radius of one another. So that I think contributed to the ease of bringing the community together.
Well, the Worcester guys are a little more than 5 miles away.
Well, that's true, but we drive very fast.
Theoretically,
I would also say that—
Boston drivers are also.
Let's talk a little bit about another—
It's about a 15-minute commute.
I'm glad you brought up the Israeli example, because one of the things that made the Israeli data so powerful is their fundamental information systems that go across their health service. So when you saw data from Israel, there were tens to hundreds of thousands of people that they were getting the data from, not 5 to 10 or 20 or 30. And when you look at the UK, you're getting the same kind of data today. You're getting tens of millions of people, and they're correlating the laboratory results, the clinical results, with the patient records. That's something we just can't do in the US. We just can't do it. And we need to do it. You know, in the previous panel, we talked about, particularly Margaret Hamburg talked about the need for a national public health services. And part of that, we need a national information system that really works. And we just don't have it. We can't do those studies. You know, it's hard enough to do it within the Harvard community. You can do it in some hospital systems with great information systems, but it's something that we need to do and we need to address, because without that kind of data, you're really flying blind. And as you had to say, you had to look over to Israel to see what's happening, not at this country, which you should have been able to do.
Yeah, I agree, Bill. I think that in my comment, really, I think you've synthesized it wonderfully, as you always do, Bill. But because the Harvard Medical School has outreach to multiple different hospitals, that allows not only the interoperability to be there, but also the desire to share. And I think that those two elements are both an important part of that equation, because like many of our large hospital systems use Epic. So Epic provides an interoperable system that you could be able to do. And there are research platforms now that Epic is laying up across their different hospital systems and health systems that utilize them. But many of the health systems involved might consider that proprietary information, either because of HIPAA concerns or also because those might be valuable, you know, having your own data and maintaining it and controlling it. So I do think that the centralized healthcare nature of Israel and the United Kingdom, with the different HMOs in Israel, facilitated that, because not only did they have that infrastructure that provided the interoperability between the places and the databases that could be coordinated, but it's also because they were really one place as opposed to multiple places.
Right.
And even with, I think George's smart comments about other academic medical centers working together, I think at one level that's true. I think at another level, though, there's always a tendency to want to protect the stuff that is yours versus others. And that then starts to slow things down. I think that's where activist groups like AIDS, et cetera, really pushed us hard, for funding, so that you basically broke down the barriers. And our whole approach in West Virginia has been, and that's really that team of teams approach, is trying to reduce the parallelism and the borders and the walls between different agencies that, when working together, could really advance the sort of the ability to respond, just like Stan McChrystal saw in the Middle East, where his most high income, sophisticated fighting force was getting their cans kicked by people that were making IEDs off the internet and moving so fast that the military top-down structure could not respond. So I think a lot of this is also trying to create that more collaborative structure, so that we see that our goal is to really improve the health of our citizens. And if we can contribute data to it, that's a benefit, not a deficit. So I do think that there's some policy and perhaps cultural issues to solve, as well as some of the technical ones.
Right. And Roberto, you had a comment.
Yeah, and I wanted to stress that importance of the databases, because you have countries also like Denmark, where you have mortality databases. You can really put your data in context. And I think one of the things I see in Mass CPR, as well as other initiatives, is that emphasis in also improving the quality of our databases. Because you go to the CDC databases, whether it's government, academia, it's messy and it's incomplete. And it's hard to analyze data, and it's hard to, if you're working on biomarkers, to have your correlates with clinical situations. And working on also, I like what Lael, Dr. Yonker said about reaching out to other communities outside your usual catchment area and incorporating as much as you can from the diversity of that you have, or we all have around us, because there is a bias. As who can go with long COVID to see a doctor and take time out of work and say, oh, I feel fatigued and I'm not the same person I used to be. And there is a bias there. And who has the money, who has the access, who has the resources, and can reach physicians who are willing to sit down more than 15 minutes to listen to you. And so we're missing an enormous amount of the population who cannot afford to leave their jobs to go and take care of and they incorporate it into their life. So working at all these fronts in a very clean, in a very systematic collaboration to bring all the data in, bring all the people, and be a more just society, and also do it internationally, because then we also have pockets around the world that are completely neglected. And then on the other end, with the databases, we have artificial intelligence, we have machine learning, we have all these fabulous things, but we don't have the right data to feed into.
Right. And I would say that when we're thinking about this problem of cooperation writ large, in this segment, which is scientific advances, we're doing really well. But there are limits to how well we can do from the information that we can get. And when you begin to expand beyond that to epidemiological data, and is this making a difference? Is that making a difference? And questions you asked, Lael, about what is the role for children in this, that, or the other, we really don't have the information. I think a fundamental lesson is we need a unified information system now. People have worked on that. It's hard enough within one medical system to do it for a country. I've done a lot of work with Singapore, and as small as Singapore is, they still haven't been able to do it. They have a lot of issues, some of which you referred to, Roberto, unless you have a strong central leader who can put it together, it isn't going to happen, right? And you really need every part of an organization. And when I talk about organization, I'm talking about the United States. We have so many competing think about the competition within one hospital system or another hospital system in New York City. Well, consider what that means for one state to another state, one country to another country. This is something we're stressing here, the importance of cooperation. We're stressing how fast it can make us understand problems and solve problems. And here, there's huge opportunities that are just not being followed up. And I think that's a lesson from this session that we want to emphasize, that we really need more than we have. This country should be a leader, and other countries could be leaders too in this kind of system, but we're just not there. I want to ask another question of George. Another aspect of this unusual about Mass CPR is the inclusion of the private sector. Private sector, the border between the private sector and the public sector, especially for vaccines, is rather permeable, to put it that way. But it's very interesting that you're able to get their cooperation. And I'm very interested about how you see the issues of intellectual property, which are so prominent in the biomedical field, mixing into this collaborative effort. What happens if somebody at Mass General collaborates with somebody at the Broad and somebody at UMass, and they come up with a brand new idea? And by the way, they're on the same call. There was some guys from one of the biotech companies that chipped in with some pretty critical inputs as well. Who's on the patent? Who owns it? Where does the money go? Those are all issues that are important issues, as you know, being in the Boston community.
Yeah. Well, the pandemic dropped many of those barriers because the urgency overwhelmed one's self-interest. And so at least in the early months of the pandemic, there was so much openness. The industry scientists came into the meetings. There was a tendency for much more information sharing because we were all united against this, this common pathogen. We were very, very fortunate. Our vaccine working group was directed by Andrea Carfi, who was from Moderna, and Dan Baruch, who helped develop the Johnson & Johnson vaccine. And I think the openness was essential to the speed of that.
And I know that the head of the Pfizer vaccine programs participated from time to time.
Yeah, that's right. That's right. Yeah. Phil Barnser was involved. Yeah.
Guys. And
So,
it wasn't public.
Yeah, in the aftermath, when things slow down, then people start to pay more attention to issues like intellectual property. I think what we learned is that there's an enormous amount of innovation and discovery that happens in the pre-competitive space, and that we all, benefit from that. And at some level, the lawyers get involved, and we execute intellectual property, and it involves discussions and collaborations among institutions. We've laid the foundation for that through Mass CPR. We have common agreements, and again, I think we've solved it in the urgency of the pandemic, and our hope is that people will see other major health issues, the mental health challenges, chronic diseases, that these will also create an imperative for more
Before we go to
sharing.
that, George, I'd like to say, what protocols or what instruments have you put in place that allow exchange? I'd like to be a little specific about this. Like when Lael wants to send her samples to Daley, is there an agreement that covers that? Does that allow for HIPAA and all the other issues that normally it would take weeks or months of back and forth to take your samples, get them from the kids, hand them over to another institution, get the data back? What have you put in place concretely that others might learn from to how to facilitate these kinds of conversations?
Yeah.
That, how have you put together a structure to handle the intellectual property? The first, it took quite a bit of effort to hammer out these consortium collaboration agreements.
which did indeed talk about sample sharing, financial
Are those
transfer.
publicly available?
I believe, well, you know, I'd have to defer to Dean David Golan, who managed most of those. I think in spirit, we would be very happy to make them publicly accessible. And indeed, you know, we have these common reliance agreements, which have at least set the stage for these kinds of mass collaborations.
So Lael, as a user, how do you use these agreements? What difference does it make to you?
So it makes life easier. I mean, I definitely, you know, they would have to, you know, follow all of the IRB requirements. So any samples would have to add them onto our protocols as well. And so we do everything that we're supposed to do from a protocol perspective. And then if it's outside of the Harvard community or outside of where we have established collaborations, then it's a little bit more has to go into it. But like I said, it had been pretty easy and prioritized, and we
Pretty
were able to
easy
work
is
through.
a great step forward, I can tell you,
Yeah, I know.
from being involved in these kinds of things before, but were never easy. To
Yeah.
take a sample from Harvard and give it to somebody at MIT was a nightmare.
Well, yeah.
Bill, if I may highlight another aspect that Dean Daley brought up in his presentation is the transition from SARS-CoV-2 to monkeypox. And obviously we're not out of SARS-CoV-2, but the fact that it's seen so much in history is that, and chronic fatigue syndrome is a good example when there's a dwindling interest, even in terms of committees and government involvement, et cetera. And then comes, you know, same will happen with SARS-CoV-2 and whatever next virus happens, and it will have its own post-viral syndrome. And we also need to, and I think that was a good promising feature, that it's not just going to be a SARS-CoV-2 focused initiative. And this is going to persist and help us throughout all the chronic diseases, as you mentioned, the microbial diseases, et cetera.
Roberto, that's a very utopian dream, but you know, I'll give you a very concrete example, and this is for you, George, which is, I remember going to Botswana, where Harvard had this amazing program put together by my good friend, Matt Sussex, that really, if you were in an isolated hut in Botswana, maybe one or two nearby huts, and you qualified for a clinical trial, you were included in an international clinical trial seamlessly. It's the most amazing thing I've ever seen. I remember talking to the health minister and the prime minister at the time. Can we extend this to other diseases? I mean, it's an amazing, okay, it never has been, even to this day. It hasn't been. And the answer is a very simple reason why not: money.
Mm-hmm.
It's money. Nobody's willing to put up the money to do that. Now, from your point of view, if you could raise the money to say, let's get the money for mental disease or for whatever disease you want, heart disease, Alzheimer's disease, we can put together these consortia for you. You know, my other experience with HIV/AIDS is I remember going to dean after dean after dean in the early days, and them telling me, we're never going to work on HIV. It's not an interesting problem. Heart disease is a big problem. This is a big problem. And the answer was, that isn't the answer. The answer was there was no money. Okay, I worked with Elizabeth Taylor and AMFAR that I helped create, and some other people. We got $300 million in supplemental appropriations in one blow. And all of a sudden, there was a very interesting problem. And that $300 million, same people, by the way, they wanted now to be the king of AIDS research. Same people that said, oh, I'm not going to take your best student. We're never going to work on that problem. Wanted all my students. Okay, all of a sudden, so money makes a big, big difference. So if you can get the money, George, or other people get the money to put together these collaborative efforts, you can do it. There's no reason you can't. You'll find people coming to you. So what fields how would you prioritize? You have a view.
Yeah, Bill, let me just quickly address
money to come from.
Yeah, let me just quickly address the prior issue. And I want to say that on the Mass CPR website, if one just Googles mass CPR and sample sharing, you will find the materials, which include things like MTA and a data use agreement template, as well as the forms that we've used to sort of homogenize sample access across our community. So that addresses that. Let me say this, you know, we've seen a remarkable concentration of extraordinary wealth in the growing community of billionaires on this planet. And that is a reflection of, you know, some very challenging and perhaps distorted tax systems and the like. But rather than having community assets managed by like government activities like the NIH, we're seeing an increasing amount of science funded through these large philanthropic endeavors. And so indeed, there are individuals who are coming forward, individuals and groups that want to solve some of these major challenges. So I talk about the Chan Zuckerberg Initiative. So Mark Zuckerberg, Priscilla Chan have announced a network of biohubs that they would like to build. And they're putting hundreds of millions of dollars and perhaps promising billions in the future to build these consortia. We in the Boston area put one of these applications together. We didn't get it because we had just recently gotten a $500 million artificial intelligence and neuroscience consortium from Chan Zuckerberg. But I think it does say that there are visionary philanthropists who are inspired by the possibility that we can bring our communities together to start to address these major problems.
So I push back a little bit by saying that if you actually look at the money that's spent, $40 billion a year at the NIH, more or less, it's a huge amount of money. And yes, these other guys who put up money, they could catalyze things, but it's not going to be the same as the NIH. We need them both, and not to say that we shouldn't.
Oh, I don't mean to disparage the remarkable NIH contributions.
Right.
And in fact, we're very thankful that there has been significant increases in the overall budget.
Where do you think Harvard should go next, or any community should go next in their focus? I know mental health is a big one for you. Where else do you think we should focus? And Clay, I'd like you to chip in there too. So George first, and then
Well, you know, what's interesting is, you know, when you take a global perspective on these conditions, we realize that, you know, COVID and other disorders are not just medical diseases, they're social diseases. And we really need to address many of the social determinants that contribute to health. And so we at Harvard have a very extensive global health network. Sadly, we just lost one of the leaders of our network, Paul Farmer, who had been the founder of Partners in Health and is the chair of our Department of Global Health and Social Medicine. But we learned that by understanding how to deliver and implement some of the remarkable science in under-resourced areas, that we can figure out how to do it more effectively and at reasonable cost. And so we bring back some of those insights and innovations into our community. I'd like to see us as a community aspire to tackle issues of brain health, and that cuts across the range of neurodegenerative diseases. Alzheimer's disease is another tsunami that's hitting us. Behavioral health and mental health. The burdens of the pandemic have proven to us how much we lose when we don't have adequate systems for supporting individuals' behavioral and mental health needs. So that's something where I'm sort of taking the lessons of mass CPR and hoping to turn them on to the challenges of brain health.
That's great. I was just, maybe it's my scientific training pushed back a little at one point you made. And my foundation has spent a lot of time looking at efficient health services around the world. Ambulance services, eye surgery, heart surgeries, and the resistance to uptake of that in the United States is phenomenal. We can do what we do at a fraction of the cost. And they're very deep entrenched reasons. That's a subject of a different conversation. But just because you can do 50 high quality cataract surgeries a day doesn't mean that people are going to do them. And that goes across the whole spectrum. And that's a lesson we have to learn about what we're really doing with our healthcare system. It's something beyond, as I say. Yes, Lael, you have your hand up here.
I just want to take the opportunity to speak up for pediatrics and say, like we've done in COVID, kids are often an afterthought and they're sort of, you know, the next step. I just want to say that I hope with all of these efforts and when, you know, when we use the infrastructure to move forward, that pediatrics is included in this and all sorts of, you know,
Right.
whatever.
So
the issues
you're
are.
feeling that pediatrics is generally an afterthought, and certainly with an aging population, all the focus on the other end of the spectrum,
Right.
it's going to be possible. I think that's a very good point, Lael. We should make sure that the pediatricians of the world have an important voice, because
Mhm.
after all, the health of those young people is going to determine the health.
And I think there's lots
population.
that can be learned from, you know, looking backwards towards younger children and can be informative. And so I think with the pandemic, there have been aspects that we've learned from the kids. For example, Miss C is an extreme example, perhaps of long COVID. And that's sort of a hypothesis that's out there that's being built upon. So I think that there are things that we can learn in both directions. And again, working together, sometimes there's really a distinction, but I think the, you know, Mass General is really great. We're integrated in sort of the Harvard community. It's really got an integrated pediatric centers as well. So I think that's important to include.
Roberto, a quick point for you before
Quick point, long-term follow-up. We have to invest in that if we are really going to understand diseases.
Clay.
Yeah, I would say, Bill, that this is a really important moment for, I think, our country and maybe beyond. And I'm going to turn back to the focus of the entire conference, which is around healthy longevity. And I'm worried that because of the perception of stress and fear and hopelessness and sort of scarcity mindset that so many people have, polarization, opposition, you know, trying to acquire more, looking at the world outside. The Sufi poet Rumi said, yesterday I was clever and wanted to change the world. Today I am wise and decided to change myself. So I think that as we look at our country, I think we have a lot of young people, as Lael was saying, who are biologically old. And when you look at the Blackburn Appel work from San Francisco, the women in their study that looked at perceived stress and biological age using telomeres, telomerase, and oxidative status of their cells also weighed a lot more. So the more aged you were biologically, 17 years being the most aged biologically, and women that average 39 years old or 38 years old as far as their age, were also heavier. And we're the heaviest nation in the country, and West Virginia is one of the heaviest states in the country. So I think that there is a lot of surrogate markers that would suggest that we are an old population, not only chronologically older, but also biologically. And the opportunity that we've learned from, I think, a number of research studies, whether it's from the Blue Zones or the Case and Deaton work on deaths of despair and hopelessness, et cetera, it's how you see yourself and see the world. So we have a moment where we can see abundance and we can work together to make things better, or we can go back to our usual ways and start to fight with each other and compete and believe the resources are scarce. And so I think that these kind of conferences are so important so we can have this dialogue, because this is the time for us to act, I believe.
Thank you, Clay. That's a very high note to end on. I would just like to thank all of you for your wonderful contributions today, from the ground up, that's you, Lael, to a long-term perspective, which is you, Roberto, who've looked at this long COVID and other similar diseases, and both of the deans for your extraordinary work. I think, as in most crises, the really bright spot is science and medicine. We do really well there. We're a coherent community. We know what we're doing. We have a very deep, deep history. And there's a fundamental trust in our community. You know, we're all in this because we want to do good. And there's, you know, we fight, but It's fighting among brothers and sisters that are in the same family that trust each other. That isn't the case when you get to many of these broader issues. And we have to say that humans are capable of extraordinary cooperation, which we see in science, we see in medicine, and we've seen throughout this pandemic. And we see with the people on this panel and the panel that preceded it. It would be wonderful if we could figure out how to extend that beyond. What are the criteria that let us be a coherent, trusting community? With all the fractions that we have, how can we get beyond that? And I think that there's the lesson is we can do it as humans. What do we need to get from where we are to a broader set of excellence so that we can all do better together? With that, I want to thank you again for your time. You're all extraordinarily busy. And I want to thank you for your participation and thank Metabesity for the opportunity to have this discussion. So back to you, Dan. Thank you all.
Well, we cannot thank all of you enough, and Bill in particular. It's just astounding what you put together in a full morning, and you've held up as fresh as a daisy at the end. And I think you're exemplifying healthy longevity as much as anybody I know. We are so grateful to the panelists and the inspiring ending that you and Clay Marsh gave us. And Clay, thank you for your service. I'm in the system over here in Harpers Ferry. My wife and I benefit from your leadership at WVU. And so we're proud of you and what you've done for the state. And we know you have big challenges. And you clearly have been looking in on the conference. We much appreciate that. Great to have Lael and Roberto. Thank you for your service. And then George Daley, I love your term catnip. Clearly, we need resources for moving things or for moving or hurting cats. And I'm going to adopt that expression. So thank you for that and all the wisdom that you've given us.
By the way, catnip for dogs is tranquilizing.
Okay. No, and you would know it, Bill.
Good to know.
Well,
Cat
thank
food
you.
just works just as well.
Well, thank you all. And
Thank you. Thanks,
we'll
Bill, for
see
a
you in
great
the future.
panel.
Thank you. Take care. Bye.
Thank you.